Glomerular diseases presenting with a nephritic syndrome are characterized by inflammation in the glomeruli. The main clinical features of nephritic syndrome include the following: hematuria, red blood cells and red cell casts in urine; proteinuria with or without edema; azotemia and hypertension. Nephritic syndrome is the typical clinical presentation of most proliferative types of GN, such as post-infectious GN, crescentic GN, and proliferative lupus GN. The lesions that cause the nephritic syndrome have in common proliferation of the cells within the glomeruli, often accompanied by an inflammatory leukocytic infiltrate. This inflammatory reaction severely injures the capillary walls, permitting blood to pass into the urine and inducing hemodynamic changes that lead to a reduction in GFR. The reduced GFR is manifested clinically by oliguria, fluid retention, and azotemia. Hypertension probably is a result of both the fluid retention and renin release from the ischemic kidneys. Acute proliferative, post-infectious and infection-associated glomerulonephritis. As the name implies, this cluster of diseases is characterized histologically by diffuse proliferation of glomerular cells associated with influx, exudation, of leukocytes, typically caused by immune complexes. The inciting antigen may be exogenous or endogenous. The prototypic exogenous antigen-induced disease pattern is post-infectious glomerulonephritis, whereas an example of an endogenous antigen-induced disease is the nephritis of SLE. The most common underlying infections are streptococcal, but the disorder may also be associated with other infections. Post-streptococcal GN is decreasing in frequency in the United States but continues to be a fairly common disorder worldwide. It usually appears 1 to 4 weeks after a streptococcal infection of the pharynx or skin, impetigo. Skin infections are commonly associated with overcrowding and poor hygiene. Post-streptococcal glomerulonephritis occurs most frequently in children 6 to 10 years of age, but children and adults of any age can also be affected. Pathogenesis. Post-streptococcal GN is caused by immune complexes containing streptococcal antigens and specific antibodies. Only certain strains of group A beta hemolytic streptococci are nephritogenic, more than 90% of cases being traced to types 12, 4, and 1, which can be identified by typing of the M protein of the bacterial cell walls. Many lines of evidence support an immunologic basis for post-streptococcal glomerulonephritis. The latent period between infection and onset of nephritis is compatible with the time required for the production of antibodies and the formation of immune complexes. Elevated titers of antibodies against one or more streptococcal antigens are present in a great majority of patients. Serum complement levels are low, compatible with activation of the complement system and consumption of complement components. There are granular immune deposits in the glomeruli, indicative of an immune complex-mediated mechanism. The streptococcal antigenic component responsible for the immune reaction had long eluded identification, but the preponderance of evidence identifies streptococcal pyogenic exotoxin B, SpB, as the principal antigenic determinant in most but not all cases of post-streptococcal glomerulonephritis. This protein can directly activate complement, is commonly secreted by nephritogenic strains of streptococci, and has been localized to the hump-like deposits characteristic of this disease, described later. At the outset, the inciting antigens are exogenously planted from the circulation in subendothelial locations in glomerular capillary walls, leading to in situ formation of immune complexes, where they elicit an inflammatory response. Subsequently, through mechanisms that are not well understood, the antigen-antibody complexes dissociate, migrate across the GBM, and reform on the subepithelial side of the GBM. Deposition of circulating immune complexes also may contribute to the lesions. A similar form of glomerulonephritis occurs sporadically in association with other infections, including those of bacterial, e.g., staphylococcal endocarditis, pneumococcal pneumonia, and meningococemia; viral, e.g., hepatitis B, hepatitis C, mumps, HIV infection, varicella, and infectious mononucleosis; and parasitic, malaria, toxoplasmosis, origin. In these settings, granular immunofluorescent deposits and subepithelial humps characteristic of immune complex nephritis are also present. Clinical features in the typical case: A young child abruptly develops malaise, fever, nausea, oliguria, and hematuria, smoky or cola-colored urine, 1 to 2 weeks after recovery from a sore throat. The patients have dysmorphic red cells or red cell casts in the urine, mild proteinuria, usually less than 1 gram per day, periorbital edema, and mild to moderate hypertension. In adults, the onset is more likely to be atypical, such as the sudden appearance of hypertension or edema, frequently with elevation of bun. The glomerulonephritis is subclinical in some infected individual, and is discovered only on screening for microscopic hematuria carried out during epidemic outbreaks. Important laboratory findings include elevations of antistreptococcal antibody titers and a decline in the serum concentration of C3 and other components of the complement cascade. More than 95% of affected children eventually recover renal function with conservative therapy aimed at maintaining sodium and water balance. A small minority of children, perhaps less than 1%, do not improve, become severely oliguric, and develop a rapidly progressive form of glomerulonephritis, described later. Some of the remaining patients may undergo slow progression to chronic glomerulonephritis with or without recurrence of an active nephritic picture. Prolonged and persistent heavy proteinuria and abnormal GFR mark patients with an unfavorable prognosis. In adults, the disease is less benign. Although the overall prognosis in epidemics is good, in only about 60% of sporadic cases do the patients recover promptly. In the remainder, the glomerular lesions fail to resolve quickly, as manifested by persistent proteinuria, hematuria, and hypertension. In some of these patients, the lesions eventually clear, but others develop chronic glomerulonephritis or even RPGN. Morphology. The classic histologic picture is one of enlarged, hypercellular glomeruli. The hypercellularity is caused by 1. Infiltration by leukocytes, both neutrophils and monocytes, 2. Proliferation of endothelial and mesangial cells, and 3. In severe cases by crescent formation. The proliferation and leukocyte infiltration are typically global and diffuse, that is, involving all lobules of all glomeruli. There is also swelling of endothelial cells, and the combination of proliferation, swelling, and leukocyte infiltration obliterates the capillary lumens. There may be interstitial edema and inflammation, and the tubules often contain red cell casts. By immunofluorescence microscopy, there are granular deposits of Ig and C3, and sometimes IgM in the mesangium and along the GBM. Although immune complex deposits are almost universally present, they are often focal and sparse.